Dr. Reaves holds a medical degree from the Medical College of Virginia and completed his residency in internal medicine at Medstar Washington Hospital Center, where he also served as chief medical resident. He has worked in primary care, hospitalist medicine, and palliative care, and hospice, both, in South Carolina, in Atlanta at Emory School of Medicine, at Medstar Southern Maryland Hospital, and currently he serves as the medical director for palliative medicine and supportive care at Adventist Healthcare Shady Grove Medical Center in Rockville, Maryland. Of note, he also holds a certificate in theology and ministry from the Princeton Theological Seminary. Dr. Reaves has particular interest in considering the cultural angles and how information about end of life is given and received, and has participated in research titled Culturally Tailored Conversations at End of Life, What African American Patients Want Physicians to Know. He has spoken widely on this topic, and I've continued to hear through the grapevine just how powerful a speaker Dr. Reaves is. And although we've known each other for a few years, this is actually my first opportunity to hear him speak in this type of forum. So Dr. Reaves, we are so grateful to you for accepting our invitation. I know I am among many in the audience who is very excited to hear your talk.
Thank you, Dr. Adams. I appreciate the warm words of welcome. Hello, everybody. Thank you to the Department of Medicine, to the Palliative Care Department, also to Pastoral Care, Spiritual Care there for having me. I'm elated to be a part of the Grand Rounds and to share a little bit about what my clinical interest is within palliative care. You know, my interest involves the intersection of faith and spirituality and how it influences end-of-life decision-making, particularly for people of color, particularly for people that look like me who are African-American. And I've had the opportunity over the last 5 years or so to be involved through the professional, through the Academy of Hospice and Palliative Medicine with people who also share my same clinical interest. So again, I'm really elated to be here, and thank you for the opportunity to speak before you. I'm going to stop sharing my face so that we can concentrate on the lecture at hand. So with all that is going on in the United States right now and in the world today, we are very familiar with the term pandemic. And I use that term pandemic to title the discussion that we're going to have today. The silent pandemic in medicine, bridging the gap to build community with African-American patients through culture and awareness. This lecture is offered for CME credit. You all know what to do as it relates to that. The three objectives for today are to recognize the importance of faith and spirituality, as well as the concept of hope, and their influences on medical decision-making for some African-American patients and families, right? We're not a monolithic group, but there are common themes that run throughout. Also, the second objective is to recognize the cultural experiences that influence end-of-life decision-making for some African-American patients and families, and also to distinguish between cultural competence and cultural humility. We'll start with a case. This is a fictitious case. However, I'm quite sure that many of us have experiences with cases such as this. There's a 75-year-old gentleman with comorbid problems of hypertension and diabetes. He comes to the hospital with fever and respiratory distress, and he's found to have COVID-19 pneumonia. He's initially placed on high-flow oxygen. However, he quickly deteriorates and has evidence of hypoxic respiratory failure, and he needs intubation. He's later found to be in septic shock. He's on multiple vasopressors for hemodynamic support. Despite treatment for the viral pneumonia, as well as other antibiotics, he's not shown any clinical improvement in the last 2 weeks or so. His chest x-rays are getting worse. It's showing worsening pneumonia. He's got evidence of renal failure, and he has started on dialysis. His prognosis is poor. However, he remains full code despite numerous conversations that the ICU doctors have had with the family. And the palliative care team is consulted by the intensivist to help with such complex medical decision-making and goals of care. I'm quite sure many of us recently have been in this scenario, and even prior to COVID, we've been in the same clinical scenario. So the outcomes of the family meeting are as follows. Doctor, you can't play God, right? My father, he's a fighter. I don't believe in DNR. You need to resuscitate him. You have to resuscitate him. You have to do everything possible to keep him alive. We're praying in God. We're praying in God for a miracle. We're hoping and expecting a miracle. We want that feeding tube. If he doesn't get a feeding tube, he's going to starve to death, right? How is he going to get stronger? Whatever happens, it's God's will, right? God has the last say. When I say those things, I'm quite sure that many of you have been in situations, whether it's the palliative care team or whether it's the internal medicine team or the ICU team, where family members have given this sort of expectation and hope that's strongly rooted in their faith and their spirituality. And I want you to take a few moments to recognize the feelings that you might have when those words are said, right? When those phrases are said. When a family member comes to you and says that they're praying for a miracle, despite the stage 4 cancer and neutropenic fever and sepsis, right? We know clinically that the outcome, that the prognosis is quite poor and not very good. However, you have family members that are giving you this constant conversation of hope and great expectation. So I think it's important to stop and pause and recognize what emotions you have, what thoughts it conjures up for you, what experiences possibly that you may have had with a family member who's been in a life-threatening situation. If you have not encountered this type of conversation or this type of spiritual expectation, you will, and it's quite common. So why do I call it the silent? Why did I address the title of the grand rounds as the silent pandemic? Because often there is that enormous elephant in the room, right? We feel it, it's palpable, we recognize it, we sense it. However, we don't often address it, right? So the American culture is typically bad about death. We have a death-defying culture. And within the American culture, within the African-American community, many African-Americans choose life-prolonging care over palliative interventions or hospice care compared to other ethnic groups. Well, what happens when spiritual talk or when expectations in a miracle, when they're expressed by the patient and the family, right? How do you balance your medical knowledge and the science with spirituality and the humanity of your patient? And does this aspect of whole person care make you feel uncomfortable? How do you address the elephant in the room? When we think about culture, we know very little about what it truly is, right? Because we only see what's at the tip of the iceberg, right? How people dress, what type of music they listen to, what type of entertainment they enjoy, what type of cuisine they like. However, there is so much more to culture than what meets the eye, and that's represented by some of the concepts that are seen below the iceberg, such as the way that we use body language, our eye contact, right? Our priority of ranking within relationships and within the family. Those are things that we don't necessarily see, right, at face value. And it's important to keep in mind when we are taking care of people who do not look like ourselves, right? Or people from another culture, to understand that there's something deeper than what we can see. So cultural beliefs at the end of life, right? Religious and cultural beliefs help people to cope. We call that religious coping. It helps them to cope with the terrible news of the the stage 4 cancer, or it helps people to cope with the stress of being in the hospital after 2 months because of COVID. It helps for the impending loss and grief associated with the death and dying, right? Religion and cultural beliefs help to bring meaning, right, to what's associated with the seriously ill patient. Even families who don't typically practice a faith tradition often rely on religion and faith and spirituality at the end of life. Clinicians hold strong culturally determined beliefs, right? We come to the table with our own experiences. And often when we counsel patients, we'll sometimes say, well, personally, this is what I believe, right? So we have to recognize that our personal feelings and our own beliefs and baggage may not be the same as the people that we're taking care of, right? So clinicians' attitudes toward the end of life can vary significantly along religious and cultural lines. However, end-of-life care in the United States has typically been rooted in the values of the white middle class, where autonomy, having ownership of your own wishes and desires is valued. However, not all cultures believe or incorporate that type of decision-making or hold those values when it comes to the death and dying, right? As I said before, when we think about the tenets or the principles of medical ethics, the one that we so often incorporate with decision making, right, is autonomy, right, where the individual has his or her own choice to make decisions for his or her own life. However, in some African American families, that principle of autonomy is not the rule of the land, right? In some African American families, the focus is really on family-centered decision-making. I want you to stop and think about the times where you have tried to have a conversation about a code status or any other type of medical intervention with an African American patient. And that patient defers to their family member, or the family member steps in to say, you know, I'm the power of attorney, I'm the one making decisions, when the patient is truly capable, right, and able to make that decision for him or herself. So it's important to recognize that the family is often the decision-making unit within some and many African American families, and it's not the principle of autonomy. So a lack of sensitivity to, right, and the lack of respect for, right, the lack of recognition for the cultural differences can truly compromise the type of care that we provide to minority patients when they are dying. When I lived in South Carolina, in 2015, I had the opportunity to attend the American Academy of Hospice and Palliative Medicine conference in Philadelphia in 2015. And it was at that time that a PhD researcher in end-of-life issues related to minority populations was on a panel and gave a panel discussion about cultural competence and cultural sensitivity in the care of the dying patient. And it was through that lecture that I introduced myself to her, and we had a collaborative effort when I was practicing down in South Carolina, where we were working together to train physicians in cultural competence. So there was a small research project that I was a part of that was an offshoot rather, of a larger project that she had been working on. However, my time in South Carolina was cut short, meaning that I wanted to come back to the DMV area to be closer to my family, and that research project was aborted. However, out of that project came some very valuable information and some insights for me that has since sparked my interest in having these type of conversations and lectures. And also out of that research collaborative came 4 videos that were culturally based to address end-of-life care, autonomy, family-centered decision-making, hospice and palliative care. 4 videos came out of that. They're currently in production and they're not yet ready to market, but I think they will be valuable resources as we further understand the importance of communication, culturally competent, culturally sensitive communication. So most patients, when they're dying, right? I'm sorry, patients who are dying are treated in the hospitals, and they're treated by physicians and hospitalists in particular. So I'd like to talk about the two topics of cultural competence and cultural humility. I think most of us are familiar with the term cultural competence or cultural sensitivity. We hear about our institutions of employment offering diversity training or training in cultural sensitivity or cultural competence. But over the last couple of years, I came across this term cultural humility, which I think probably should be employed more so than cultural competence. Cultural competence implies that you, the provider, right, are the expert in how to care for or how to understand and recognize the cultural issues with a particular ethnic group of population, right? Competence assumes that you have a thorough knowledge, right? That there is an end product, and with that knowledge, you can sit down and take a test and get scored, right, on your level of competency, right? However, cultural humility is an ongoing process where you recognize that you are not the expert, where you recognize that the teacher, that the expert is your patient, is your family, right? And that you can always learn through their examples and through their wisdom and through their sharing of information with you. It's acknowledging the differences and accepting the person for who they are. So cultural humility should really be the type of posture that we all have when we encounter people of different cultural backgrounds. When doctors are trained in the culture of the people that they take care of, we, the physician, the clinician, right, we feel better about the care. Patients and families are more satisfied. There's increased level of trust between the patient, family, and provider relationship, and it leads to a reduction in the health disparities that are often and well documented in the medical literature between white patients and Black patients. As I said before, I was involved in a small research project in Orangeburg, South Carolina. When I left this area in 2002, my first job out of residency was in Orangeburg, South Carolina with a physician in private practice. I did that for 3 years. I lived in the county of Orangeburg. I worshiped in church in the city of Orangeburg. I was socially involved through my fraternity and other affiliations within Orangeburg, and I was well integrated into that community. So I got to know the people. I got to understand the community. Orangeburg is a small town. The city itself is small, but the county is the second largest land-sized county within the state of South Carolina. And it is situated smack dab between Columbia in the middle of the state and Charleston on the coast. Although this population says only 13,000, the city of Orangeburg itself is small, but the county is about 95,000 people or so. It's largely an African-American county. It's a pretty impoverished county, but one of the special, unique things about Orangeburg is that it is the home of Claflin University, which is the oldest and private historically Black college and university within Orangeburg, and right next door to it is South Carolina State University. There is an undercurrent that still exists there of racial tension because of the history of slavery. You know, South Carolina, Charleston in particular, being, I believe, the largest port of entry for many African people coming to this continent. 70 miles to the east of Orangeburg is Charleston. So there's a tension that still pervades that atmosphere. There was an incident within Orangeburg back in the late 60s because of tension that occurred between college students at South Carolina State College at that time, as well as local white residents, where they were protesting, from what I understand, they were protesting the segregation of a bowling alley. And there was a great conflict and a mass demonstration entitled, a mass demonstration, which is known as the Orangeburg Massacre. And to this day, every year on the anniversary of that horrific occasion, there's a memorial and a recognition of the lives that were lost, of the 3 Black lives that were lost in the Orangeburg Massacre. I say all of this to say, to paint the picture, right? To paint the picture of the environment in which I worked. I had the privilege of working at the Regional Medical Center, which is the only hospital in Orangeburg County. And I say I had the privilege to work there because in Orangeburg, in South Carolina, I had a lot of my first, and I gained a lot of medical knowledge and experience, and I truly believe that I rendered great care to the people that were patients in that hospital and to the families in that community. However, within the community, particularly within the Black community, this particular hospital is known as the Death Hospital, right? Or TRMC, the Regional Murder Center. Those are things that are said in the community because of the history of medical mistrust, medical mistakes, deaths that have happened, the number of amputations that have happened in that hospital. There's not a lot of trust from the African-American community for the care there. However, that is the hospital where many people receive their care. I won't bore you with much of the study methods behind the research project, but I would like to share with you the type of research that it was. It's called community-based participatory research, which is research that is based in the community, right? And it is based in the community to better understand the community and how it works. It's a partnership between the academic community as well as the local community to provide a culturally sensitive framework. And in that the community-based participatory research, within that research, we had to first find a group of people in the community to advise what would be important in the research. And that's called the Community Advisory Group. These are just some pictures of that group. These are people that were well respected in the community from various walks of life in the community. They were responsible for designing this particular pamphlet, detailing the research project. In particular, what's special about this pamphlet is that it depicts people of color. But the important thing that I want to share with you that came out of that community advisory group is that in order to understand, so the research project was to help train physicians in culturally sensitive conversation. And the advice of the community advisory group was to first consult with the pastors. Because in that community, there was a recognition that if anything were to get done or to be effective as far as building rapport between the community and the hospital and the medical system, it first had to come from the church. It had to come from people, pastors, that they believe. So that was our first group. The second group comprised the families and patients of, of patients who had gone through a palliative care experience at the hospital. So that was my part of the research project. And as I said before, it did not, we were unable to complete it. So we were unable to implement a communication training for hospitalists, because I would have been the palliative care physician to conduct that training. But since I was no longer there, it did not come to fruition. However, as I said earlier, that project was an offshoot of something larger that Dr. Elk had been working on. This year, she has published this particular article entitled "Developing and Testing the Feasibility of a Culturally Based Telepalliative Care Consult Based on the Cultural Values and the Preferences of Southern, Rural, African American, and white community members," right? A program by and for the community. This study took place in Beaufort, South Carolina, which is on the coast between the border of South Carolina and Georgia. And this particular hospital would only allow Dr. Elk to do the research if she included people of the white community, right? So we looked at both ethnic groups to understand what things, what issues, what topics were important to them when it comes to using palliative care for seriously ill patients and or family members. Some of the themes that came out of this research project where both ethnic groups were equivalent were the disrespectful treatment of patients and families by hospital physicians. Now, what I want to share with you, I think that is a major take-home point, and one point that I learned from Dr. Elk through her topic, a practice which I had been doing even prior to hearing her project, is that for African-American patients and African-American patients, it is important to address them not by their first name, how are you, Sally, or how are you, Joe, but by how are you, Mrs. Jones, or how are you, Mrs. Johnson, right? To address people by their title, so to speak, Mr. or Mrs. or whatever their other title is, their salutations or whatnot. Unless they tell you it's okay to call me Bill, right? But it's very important and seen as very disrespectful to talk or to address patients by their first names. There were other themes that were similar, but had some degree of variation, right? Religion and the church were important to both ethnic groups. However, in the white ethnic group, it was the church members, right? The support that they got from their church family, the members of their church, that was more important. However, in the African-American ethnic group, this group considered more than the people in the church, but they considered the whole concept of religion and faith to be such a central core of their lives that decision-making could not be made without addressing this in their care. Themes that were noted to be divergent, themes that the white ethnic group did not share with the African-American group were that hopes and miracles were always possible in the African-American group. God was the one who decided life and death in the African-American group. And these themes, as I said before, were not observed in the white ethnic group in this particular study. So you might ask, why are you talking about, these things that are happening in the rural South? We're here in Washington, D.C. and the greater metropolitan D.C. area. But it's important to know that many people of color who were born here generations ago in the United States migrated to the north, right? Migrated to this area. Although Virginia, DC is still considered the South, we're not the deep South, right? So the Great Migration is the reason why many people of color left the South to seek better jobs, more financial security, to escape racism, to escape unequal living rights. So it's important to recognize that these people bring with them, right? They bring with them their cultural experiences. So when you think of people here that you might see who might be a second generation Washingtonian, they may truly still have roots that are in Alabama or South Carolina. So it's important to know the demographic that we serve. This is just a representation of the African-American migration from the early 1900s until the late 60s, early 70s. And you see people came to the East Coast, right, to Philadelphia, to Connecticut, to New York. I can tell you when I was in private practice in South Carolina, my question would always be for people who were still working or for people, I'm sorry, who were retired, who were seeking primary care, who had just moved to the area. Why are you here, right? What brought you to Orangeburg, right? Many of them were coming back home, right? Many of them left when they were children in the 30s and the 40s, and they were coming back home. So it's important to recognize that many African Americans who are on the West Coast, who are in the Northeast, have deep ties and deep roots to the South. It is said that African Americans, that we cost more, that African Americans cost more at the end of life, right? People fight to the end to keep hope alive. Though African Americans represent approximately 12 or 13% of the US population, African Americans are responsible for a considerable amount of the healthcare expenditures related to the end of life, deemed by the last 6 to 12 months of life. African American patients and families are less likely to choose hospice care. And when you look at African Americans who are eligible for Medicare, compared to their white counterparts, they use hospice services and the hospice benefit much less. African American patients are more likely to choose intensive care over white patients where the cost is greater. And African American patients are more likely to request things such as feeding tubes and chemotherapy and other interventions that may not be medically effective at the end of life. Let's talk about barriers to end-of-life care. Many people may be familiar with the Tuskegee project, the Tuskegee syphilis experiment, where many African-American men were experimented on when they were, when the natural history of syphilis was studied in them, when there was a treatment and they were denied it. We also think about Henrietta Lacks, whose cells are currently and still being used for medical research, where her cells were taken without consent. These healthcare, these medical distrust and mistrust issues still exist today. We also think about the disparity of color, where we represent 12 to 13%, whereas we represent 12 to 13% of the population, we represent a very small number of people who are in medical school, right, of medical students. And we represent an even smaller number of practicing physicians in the United States. When we think about hospice care, there's a misperception about hospice. The most common of which I believe is that hospice is a place, right? It is a venue. It's a place where you send someone to forget about, right? To die. Hospice, when many times when hospice care is not introduced by the term hospice, right? But defined by what it can provide, many African-American patients say, oh, that's exactly what I want to do. That's exactly what I'm looking for, right? But then if you introduce it by the term of hospice, you may get much more resistance and less acceptance of that particular care philosophy. There are educational gaps in end-of-life care, particularly when we as providers are not as forthcoming about what the prognosis is, when we sugarcoat things, when we don't define all of the different component parts of the medical issues that are going on as one, when we don't give meaning to what we're saying, when we don't give meaning and define what we're explaining to people, that can greatly impact their resistance to hospice care. And as I've already mentioned before, the topic of spirituality, faith and spirituality are quite important in many African American lives, where there is a recognition that God is in control, that there is a degree of suffering through which their loved one or through which they personally must experience, because suffering is redemptive, because Jesus Christ, he suffered. So why should I not suffer? There was an interesting article that was published in 2015 by Dr. Ramona Rhodes that took a look at the barriers at end of life from the provider perspective. The things that I shared with you on the previous slide are issues rather, that are borne out in the literature. Those are consistent issues, barriers to end-of-life care for African Americans that are borne out in the medical literature. However, this was the first article that I've come across that looks at the barriers from a physician, from a clinician perspective. And those barriers include family barriers, where the patient might be ready for comfort. The patient knows that they're dying. The patient wants to accept hospice, but you've got the family member who is coming in and saying, Mom is not ready for this, right? We want more treatment. We want more care. I'm quite sure many of you have found that, that people understand what's going on within and they're ready, but they hold out because of the support system around them, because of the family around them. Again, another barrier is conflict with spiritual beliefs. It's in God's hands. God is in control. God will take care of it. The desire for more aggressive care. I've had several instances recently with Latino families and some Black families at my current hospital during the time of COVID, when we were having goals of care conversation and people were not doing well, right? Where the patient was not doing well at all. And the handwriting was on the wall, so to speak. We could see that they were dying. And though we were having sensitive, empathic, frequent conversations with the family, not pressuring them to do anything, not pressuring them to make a decision, but just being there to support them, there was this notion that we were having this conversation because we wanted to take something away from their loved one and give it to someone else. So I think it's important to recognize that for some ethnic minorities, for some African Americans, talking about hospice can mean that you're wanting to take something away from me and give it to someone else. I should be just as deserving as that medical care as the next person. All of those things, right? All of those perceptions, whether they be just a perception or whether they be lived experiences, right? Through generations, all of those are important to be aware of and to understand, because they help, they strengthen medical distrust and medical mistrust when we really want to do everything to improve the relationships between our patients and families. People believe that hospice care bumps you off. I often have a conversation with my families that morphine, right, the M word, is a word that many people are afraid of. And I let people know at the beginning, you are the one that, you are in control, right? If you don't need morphine because you are otherwise comfortable, we don't give morphine, right? But if your behavior shows, if your symptoms suggest, right, if your behavior suggests that you're uncomfortable, I let you guide the treatment, right? So we give you medications, right, as your body needs. And there will come a time where the symptoms will become will increase in intensity, where we may need to give medications more often than just on an as needed basis. So having that level of open communication with people, what hospice care is not meant for, what morphine or opioids are not meant to do, to allow them to understand why can potentially impact people's acceptance of hospice care and palliative care. And again, another barrier is the acknowledgement that illness, acknowledging, claiming, owning what's going on might hasten your death. In South Carolina, I was so taken aback in the early part of my career by the number of people that would say, after being told about their medical issue, I'm not claiming that. I'm not going to claim that, right? I call that the I can't claim it theology. And I really wanted to understand what that meant. But there is a scripture that talks about speaking things into existence. So if you don't claim it, if you don't say it, it's not going to happen. Is that healthy? It's a way that people who have suffered in many different areas, it's a way that they cope. And it's important to recognize that. It is important also to really understand the significance of church, pastors, and faith leaders in the lives of many African-American patients and their families. It is the church where people run to for encouragement. It is the church where people go to pray, to lay their burdens down. It is the church where people go and ask for prayer because they've just gotten bad news. It is the church that helps to support them, right? To lift them up, to encourage them. So we have to truly understand the deep significance of how important the church is to many African-American families. In 2015 in Philadelphia, at that same conference where I met Dr. Elk, Pastor Corey Kennard was on a panel. And this is perhaps, for me, this was at that time, and this still for me, is perhaps one of the most impressive pieces of data to think about. 52 weeks in a year. Many people in the African American go to church twice a week. Wednesday night Bible study, which may be for a couple of hours. Church service, which may be for a couple of hours on Sunday. Sunday school, which may be an hour or so before church. That's roughly 6 hours a week in church, 312 hours per year in church. For a person who has attended church for 60 years of their lives, that is 18,000, almost 20,000 hours of time that is filled with messages, sermons of hope, messages and sermons of uplift, of encouragement. And that's almost 6,000, just over 6,000 hopes of conversation. So when you think about all that the church provides to the patient in the community prior to coming into the hospital, we have a lot to fight against, so to speak, right? So when you think about the 20,000 lifetime hours of hope that an African American who is in church may experience, right? It's not a fair partnership, right? There's such an imbalance between hope and then the 1 or 2 hour family meeting that a palliative care team might have about how poorly someone is doing or how awful it is to have to tell you that the cancer has recurred, or maybe the 5 to 10 minute meeting that a hospitalist team may have about the bad news that's going on, right? In the article that Pastor Kennard authored, he also mentioned he also mentioned how the names of churches imply, right, what they provide. And I'd never thought about it like that. There's Hope Baptist Church. There's Faith Baptist Church. There's Miracle Temple. There's Victory Tabernacle. There are all of these monikers or names of churches, right, that imply what people go there for, right, what people are looking for from the church. As I said before, if you don't claim it, if you don't say it, if you don't speak it, it won't happen. Death and life are in the power of the tongue. My apologies for missing the citation on this particular slide, but these are spiritual beliefs or areas of conflict with hospice, spiritual belief conflict with hospice seen in African-American patients as done by the research of Dr. Kimberly Johnson down at Duke University. Only God can decide. People don't, there's some African-Americans who have a misconception about what hospice is. It's not there to bump you off, right? It is not physician-assisted death. Miracles can happen. The study from Beaufort suggested that many African-American families and patients still believe that miracles can happen. And more so than not, I think it's important to recognize that the doctor is God's instrument, right? The doctor is not the end all be all, but God uses the doctor, right? The doctor is the instrument for God's care. And that's a tenet that many families that I have worked with have said. They have expressed appreciation for the bad news that I've had to deliver. And then in the other breath, they have said, I thank you for that, but God has the final say. We appreciate you. We thank God for sending you, and we're still trusting in God for this miracle to happen. I heard this quote on the radio. I don't know how long ago it was, but, and I'll wind down pretty soon. But the comedian Dick Gregory said, so now they're trying to get us comfortable with dying. How many of us use the term comfort care and hospice when we're talking to our families of whatever color or ethnic persuasion? So when many African Americans are fighting to get equality and fighting to lessen the gap between the healthcare, the healthcare disparities, now we're talking about hospice and comfort. So you want us to be comfortable with dying. So because time is short, I'll go to the last couple of things that might be helpful to you when you're having conversations with people of color. What happens when your family or when your patient is looking for a miracle, right? What happens? How do you feel? Like thinking back to that family meeting, right? That we introduced at the beginning of this conversation. How do you address that miracle? There is a great article that I recommend each of you to read. It's a very easy read, and it gives you some pointers on how to address a miracle when a miracle is brought up in the conversation. First, you should emphasize non-abandonment, right? Frequently, I think providers, because we clinically understand where the disease is, if a family is not accepting hospice and palliative care, we can become disengaged and disconnected, and I think at times provide less than optimal care, no matter what the color. That's just my clinical experience, right? But for people who are making that decision to continue to seek treatment when the outcome may not be any different, we have to let our families know that we're still going to be there, right? We have to let them know that we're still going to take care of them. When they say, I'm hoping for that miracle, ask, what is that miracle? What does that look like? How do you think that miracle might happen? And sometimes that miracle is one for full recovery, where people are saying, God's going to take the cancer away. Or sometimes that miracle is like, I'm so happy that my son has come home. I haven't seen him in 30 years because we weren't getting along. Sometimes the miracle is in ways that we're not fully aware when we make an assumption about what that miracle is. So the most important thing to do when a family or a patient expresses their hope in a miracle is to ask. And then once you acknowledge that they're expecting a miracle, let them know that it can happen even with what you're doing. God doesn't need us to have the miracle to occur, right? God can perform the miracle on God's own. This is a mnemonic that I found in some oncology literature that basically says the same thing, just in a different way. To affirm the patient's belief, right? To meet them where they are, to educate from your role as a provider about what you're there to do, and no matter what, let them know that you're there with them through the journey. So that's the Amen mnemonic. Out of the research project came several questions, several things that the community advisory group and the focus groups thought were important. And I won't read through all of those, but a couple of them I will just highlight. Number 2, how do you want the doctor to talk to you and your family about your medical illness, right, and the treatment? How do you want us to talk to you about the prognosis? And then number 3, what important things do you want your doctor to know about you and your family, right? By asking these types of things, you're demonstrating that you have a personal vested interest in that patient and family, and that may tear down the walls of distrust. Hope and uncertainty can exist side by side. What other things might we consider to help bridge the gap? There's an opportunity for community outreach, partnering with local faith communities, local churches about hospice, palliative care, and about advanced directives. Making educational tools, videos, or pamphlets that are culturally appropriate, using images of the community which you're serving. Also relying more on the services of the pastoral care and chaplaincy department at your institution, recognizing that when people come through the door, they do have a faith in medicine, they have faith in man about what you can do, but they also bring with them their spirituality and their faith, and all of those things, all of those aspects of whole person care truly need to be addressed when someone is critically ill in the hospital. And then the other part is something that I have struggled with in my 10 years of doing palliative care, not pressuring patients and families to choose hospice or palliative care. And why do I say I struggle with that? Because all of us as providers, we have certain duties or certain responsibilities that we must meet in addition to providing excellent care. We have to be mindful of the mission of our institutions. We have to be mindful of the quality metrics of mortality, length of stay, decrease in readmissions. And we know that this end of life population, no matter what the color, can be attributed to some of those poor performance metrics. And so we have to be able to balance great, compassionate, culturally sensitive care against the mission of the hospital in which we work. Final take-home points. Remember that the patient and the family, they're the expert. We must humble ourselves to learn from them, and that the process of learning is lifelong. And it's not about you. As a young physician, as a physician early in my practice, when people did not receive what I had to say, or I felt that there was tension or conflict in the room, there's a tendency to take it personally because we feel that as medical professionals, right, we have possibly failed in our duty and our obligation to the patient. But whatever that emotion, that anger, that fear, the profanity, whatever that environment is like that you're in when you're having this tough conversation, it's not you, right? Brush your shoulder off, recognize that it's about the person and their family so that you're not jaded when you move forward. I think this is my last slide. The pastors in Orangeburg wanted us to know that it's important to always convey hope, even in the midst of uncertainty, to convey hope, even when the prognosis is grim, to treat African-American patients with respect, and by that, honor people by the golden rule. Treat me as you would treat your own family. With that, I have ended the conversation. I'll use the word hope, but I pray and hope that there was something from this conversation that hit home, something that you can take from this to better build rapport and relationship with your patients and families. And don't take it personally. Continue to do your best and know that if things don't work out the way that you want, what people decide in their family, what family dynamic is going on there, you can't always heal and fix. You just have to recognize it and give room to it. Thank you very much.
Dr. Reaves, thank you so much for your talk today. And I can tell you that even during the talk, people were texting me to say how important what you have been sharing is. And I've gotten a couple of questions, and we're right at the hour, so we'll at least try to get one in here, which is from one of our senior administrators, Jessica Schmidt. She said she wanted to know, she said sometimes the whole family decision model can cause tension. And what do you do, or how do you handle it, or have you seen people handle it well when you are one person in the medical science field and you're working with family members that are more faith-driven, and how do you navigate the terms of family tension with different opinions?
So it's been difficult. I had an experience maybe a month ago that was not the most optimal, and I'm quite sure if anyone looks at my billing for the day, they'll ask me, well, what have you done? Because I spent the whole afternoon trying to navigate the conflict that was happening between two granddaughters, one of whom was the POA, two daughters, right? And other family members, right? People who lived out of town, some people who lived locally. And I tell you, in the midst of COVID, it's been particularly more difficult because it's hard to we can't get everyone around the table, right? To be able to allow them to vent and to voice what their concerns and feelings are. If you have the time to talk to several of the family members at one time, give them that opportunity so that you can allow them to share what they need to share. You know, I would advocate that, you know, especially since we all can't get together, you know, around the table. We can't always fix it, you know. The family dynamic has been going on for years, and we have to let family members know that we're not here to fix, you know, your broken relationships, but we're here to focus on your mother, your father, the patient at hand.
Yeah, I think that that's so helpful. I have to remind myself a lot that I can't fix it. I'm just trying to make it better.
You're trying to make it better, yeah.
I'm going to ask a quick question that I have gotten frequently from fellows, and I think is really relevant to your talk, which is you spoke about how influenced people were by their spiritual and historical personal backgrounds. I've had so many these are actually palliative fellows who are very well intentioned in wanting to engage with their patients, and they haven't really known how to start that conversation, specifically around spirituality and faith. Is there anything you can offer to our group about how to ask some of your patients if there's something important that we should know regarding faith or religion?
So sometimes I'll just ask, right? How important is faith important in your life? What gives you meaning in life? I'm blanking on Michael's last name right now. I can see him, but Michael over at the palliative care physician over at Washington Hospital Center, he'll just ask, "What do you believe?" Right. So you know, simple things such as that can open the door to a deeper conversation.
I love that. What do you believe? And that actually will change my practice a little bit. So thank you. I'm going to give one last final question from Dr. Sharma, who we've actually been going back and forth a little bit, trying to figure out how to ask this the best way. But I think Dr. Sharma is trying to ask, you've described a real discrepancy for African-American patients versus other patient populations in sort of the way that needs around communication, as well as how some information is received. And I think Dr. Sharma is curious, do we see those same patterns in other countries, or is a lot of that also influenced by our history of slavery and Tuskegee, and are some of these themes common other places as well with similar sort of diversity?
So definitely, right, definitely our history, right, the foundation of our country has a lot to do with the mistrust, the distrust of African-American patients. But the literature also shows that other ethnic minorities approach end-of-life conversations the same way and have some of the same issues about hospice services, about the use of opioid medication. So it's not just African-American patients, right? And if you were to compare Latino groups and some Asian ethnic groups regarding the same thing, the issues that we're discussing, you'll see a lot of overlap even within. So in that instance, we're sometimes more alike than we're different, although we're talking about the things that give us a different perspective, right? Some of our attitudes and beliefs are actually very similar.
I think so. It's 1:04. We're a few minutes over. I think we could there's probably need and interest in a much longer conversation, but we have always told everybody that it's an hour-long grand round. So I just want to say thank you so much. There's messages on the side of here that I hope you're going to catch about how much people liked your talk, and I have had a bunch that came in through my email. So I just want to let you know this was so well needed, appreciated, and we are so grateful to you. Thank you for your speech.
Thank you for having me. I greatly appreciate it.